Good morning, good afternoon, good evening, depending on where you are in the world. We're very excited to be launching the KBMO Diagnostics Cardiovascular Inflammation Test. Again, as we did with our food inflammation test and also with the gut barrier panel that we launched recently, we've been very fortunate to have brought on some real kind of industry experts to kind of update you on not only the markers that we've included in these panels, but more importantly, the interpretation. So again, with no difference here, we're very excited to bring on Dr. David Wright. For more than 40 years, Dr. David has delivered tangible results to thousands of patients through the delivery of a progressively refined, science-based, practical approach to the prevention of heart attack, stroke, and diabetes. His career-long passion for teaching medical students and residents now focuses on helping his peers understand and apply the ever-changing science of prevention in a real-world setting. He's been a speaker on the science of cardiometabolic prevention since 2011. So I'm very excited to have Dr. David talk about our cardiovascular inflammation test. So without further ado, over to you, Dr. David.
Thank you, James, for that intro. And thank you, audience, for tuning in and learning more about better ways to test your patients so that you can deliver better outcomes in their care. Today, what we're going to focus on is cardiometabolic conditions. And I want to emphasize that early detection is critical in this area. We're all familiar with early detection saving lives when it comes to cancer, but maybe you're not so familiar with early detection saving lives and extending health span for conditions such as diabetes, heart attack, stroke, and even dementia. These diseases of aging are not inevitable if we can find out the risk factors and take steps early on to bend that curve and give them a healthier, longer quality of life. These conditions absolutely fit the bill for prevention. There are certain biomarkers that we'll talk about today that allow that early intervention. And once you have the better knowledge, you can make better decisions and guide your patients towards healthier outcomes. One of the truths is that most of these people don't even get tested until the disease is already obvious. They've already had their stroke. They've already been diabetic for a number of years before they even are seen. And getting testing earlier is the key. I know all of you rely on the standard lipid profile. I just want to remind you that it's a starting point for that risk evaluation. It's a great lifelong predictor of risk, but it's not an immediate near-term predictor. So let's use it for what it's intended, identifying some of the long-term risk for heart attack and stroke. And as a reminder, total cholesterol includes all of the different varieties of cholesterol: LDL, HDL, VLDL, and even IDL. When I talk to my patients about LDL, I help them remember that it's the bad one because I call it the lousy cholesterol, and it helps them remember that. And we want it to be as low as possible. The majority of cholesterol is in that form. The standard profile uses a calculation to figure out the LDL. And that calculation can be affected by the triglyceride level. The testing panel that KBMO offers uses a direct LDL measurement. So it's not a calculation, it's a direct measurement. It's highly accurate at telling you what the LDL cholesterol is. Triglycerides are carried as VLDL, and we now know from recent science that triglycerides are indeed a direct cause of atherosclerosis. That's been debated for much of my 40-year career, but in the last few years, we now have proof that triglycerides are directly causative of atherosclerosis. HDL cholesterol, I tell my patients that's the heavenly cholesterol, and higher is better. That helps them to remember it. And for the most part, higher is better when it comes to HDL cholesterol. So that's the standard lipid profile. But guess what? 50% of patients the day of their heart attack have a normal standard lipid profile. Now, that's for a variety of reasons, including the fact that many patients are already on a statin drug. But regardless of the reason, a standard lipid profile can be normal and your patients are still at risk for heart attack. In fact, the standard lipid profile has a couple of calculated values that can improve your risk assessment in patients, and we're going to talk about those. The KBMO panel has these different biomarkers, and we're going to go through each one of them. I've already talked about direct LDL, and we've touched on HDL. So those are well known to each of you. But I want to go through some of the other lipid tests that are included and then progress on to some metabolic and inflammatory panels. Dividing the total cholesterol value by HDL is an excellent indicator of what's happening in the arterial wall when it comes to plaque formation or plaque regression. In fact, studies show that if that ratio is above 4.5, they're definitely progressing towards more and thicker plaque production. Above 5.5 is the highest risk. You'll notice that it's not until that ratio gets below 2.8 that you really have optimally allowed for regression of plaque. So using these different cut points helps you to better discriminate which of my patients do I need to take closer care of both their cholesterol level and their HDL level. Things like more exercise, restricting carbs to raise HDL level, making decisions on statin therapy in terms of lowering total cholesterol. So again, let's use this ratio as a way to gauge what's the impact at the arterial wall level. Further, if you look at triglycerides to HDL, we can make some predictions about the likelihood of insulin resistance. Something that many of my colleagues don't realize is that 70% of their patients that have plaque have insulin resistance. If you want to bet your colleagues whether or not a patient has insulin resistance, pick the ones that have plaque and you'll be right 7 times out of 10. Not only that, but 90% of all people with insulin resistance are undiagnosed. This is a huge pool of patients that are waiting to be found so that we can intervene. It's not uncommon for me to hear over the years, not recently because I'm focusing on prevention, but in prior years, I would hear patients tell me, well, you know, Dr. Wright, I had my heart attack and I must have caught diabetes in the hospital because they told me I'm also diabetic. Well, that patient was insulin resistant already and was finally diagnosed during their hospital stay. Well, a clue to this thing called insulin resistance is the triglyceride HDL ratio. When people are insulin resistant, they overproduce insulin. And I tell my patients that insulin is a fat fertilizer. It makes people grow around the waistline. It's a plaque fertilizer. It makes plaque grow faster and thicker. It's an inflammation trigger, putting that plaque at risk for plaque rupture. And it promotes clot growth. I mean, that's the perfect recipe for an atherothrombotic event causing heart attack or stroke. So let's find these people. Well, part of the plaque fertilizing properties of insulin are it tells the liver to make more triglycerides and less HDL. And that's the science behind this ratio that's been known about for many years, but isn't taught to most of my colleagues. It turns out that this is also related to your patient's ethnicity. And if their triglyceride HDL ratio is above 3.5 and they're Caucasian, they are likely to be insulin resistant. Notice if they're non-Hispanic Blacks, a ratio above 2 predicts the likelihood of insulin resistance. Let's think about that. Their triglyceride could be 100, and if their HDL isn't above 50, they have a high risk for insulin resistance. Well, 100 on triglycerides is normal, 49 on HDL is normal. So again, this is one reason a standard lipid profile can be misleading about risk. So you'll get on your reports this triglyceride HDL ratio, and you'll be able to, again, refine your risk assessment and treatment recommendations. Europe has known for many more years than the US that apolipoprotein B is a much better predictor of risk than LDL cholesterol. Let's talk briefly about the science behind that. Remember that LDL is a fatty substance. It doesn't dissolve well in water, and yet the bloodstream is mostly water. So it has to be carried, cholesterol has to be carried wrapped by a protein, in this case, ApoB. That protein makes the cholesterol particle soluble in the bloodstream. There's one ApoB strand for every package of LDL cholesterol, every package of VLDL cholesterol, every package of ILDL cholesterol. In fact, all of the dangerous atherogenic cholesterol particles are wrapped in ApoB. Because of that, it's an excellent predictor of risk because you're actually measuring the number of packages of cholesterol that can get trapped in the arterial wall. In fact, I tell my patients that think of this ApoB as a suitcase that's carrying cholesterol. And once that suitcase gets trapped underneath the endothelial lining, the cholesterol within it gets oxidized, and that triggers the inflammatory response and growth of plaque. Knowing how many suitcases full of ApoB are in your patient's bloodstream helps you better assess their risk, because LDL misses the VLDL and the IDL. And oh, by the way, another particle we're going to talk about in just a minute called lipoprotein A. Less than 5% of Americans have been tested for ApoB, and yet it's the single best cholesterol predictor for heart attack and stroke. I mentioned lipoprotein A. This is a genetic trait. I'm sure you've heard about it. I'm sure you've thought about it. And perhaps you've followed the recommendations of some of the organizations that say it doesn't make sense to test it since we don't have a, quote, treatment for it. Well, there's a lot to unpack in that statement, but let me just share that 1 out of every 3 of your patients has this genetic trait. We know that it doubles or even triples their risk of cardiovascular disease. It's much more common in Caucasian patients. Why would we not test for a highly potent risk factor for cardiovascular disease? Number one, your patient will benefit from that knowledge. Number two, because it's genetic, their siblings and their children will benefit from that knowledge. And remember, it's invisible on the standard lipid profile. It doesn't show up in any way, shape, or form. It is attached to an ApoB particle. So ApoB, part of that number, includes the lipoprotein A component. So that's yet another reason to get ApoB measurements on your patients. To the question about what do I do about it, there are excellent articles that tell us that aggressive optimization of all risk factors for cardiovascular disease helps to offset the genetic risk affiliated with lipoprotein a. So again, this is a motivator for patients to really get engaged in lifestyle and optimizing all of their treatment that you've outlined for them to offset this genetic risk. And oh, by the way, pharmacologic therapies are in the pipeline. They're going to be approved in the not too distant future. So knowing which of your patients have this risk factor is a huge benefit to them as well as to your recommendations. Let's move on from lipids now to some metabolic testing. You might be surprised to know that half of our fellow Americans are either diabetic or pre-diabetic. And that number is growing. It's going to be 60% before too long. We know it's happening to younger and younger people. The epidemic of type 2 diabetes in adolescents is evidence of that statement. Right now, more than 37 million Americans are diabetic, and a quarter of them don't even know they're diabetic. Tremendous opportunity for detection if they simply get the right test. Nearly 100 million Americans are pre-diabetic or insulin resistant, and 80% of them don't know it. Let's help them to know that they're at risk, and let's use some simple tests. We've talked about the triglyceride HDL ratio as one, but we'll talk about how to better use the fasting glucose and the A1C. Well, why are these statistics the case right now? The bottom line is patients don't have symptoms until their sugars are above 180. And yet diabetes is diagnosed well below that number. They don't get thirsty. They don't have frequent urination. They're unlikely to get different yeast infections until they have florid diabetes. So don't rely on your patient's symptoms to decide who to test for diabetes. Remember that the fasting glucose is simply a snapshot, and it is normal for at least 20 years before people are diabetic. In fact, a truly optimal glucose, fasting glucose, is below 90, and yet we don't diagnose prediabetes until it gets up to 100. Well, as they're going from 90 to 100 year after year, their insulin resistance is worsening. This is the time to intervene. This is the chance to start talking to them about lifestyle and maybe even some of the medications that are available for insulin resistance. Remember that the A1C is a 60-day average, and it doesn't rise until about a decade before the diagnosis of diabetes. So let's be aggressive at using these tests, and let's use the cut points that are in the literature. I've put these together in a table for you. So fasting glucose, less than 100 is normal, but you've heard me say that less than 90 is actually optimal. Prediabetes is from 100 to 125 fasting, and then diabetes is above that. Any single reading that's non-fasting above 140 is also a criteria for diabetes. But on the fasting test, these are our cut points. For A1C, truly optimal is below 5%. My guess is not many of your patients are below 5%. But normal is considered up to 5.7, and then prediabetes from 5.7 to 6.4, and diabetes above 6.4. If you will systematically test all of your patients, you're going to uncover some of those 80% of pre-diabetics that don't know that they're pre-diabetic, let alone those that are diabetic that don't know it. Lastly, let's talk about homocysteine in terms of the metabolic testing. Remember that homocysteine is just a part of the normal breakdown of proteins. Proteins are made of amino acids. Homocysteine is one of these that has methionine in it. And elevated levels are associated with the risk for both atherosclerosis and dementia. In fact, the dementia risk papers published within the last 10 years show a level above 11 is associated with a higher risk of dementia. And for heart disease, levels above 30. And as with diabetes, as with the lipid markers that we talked about, there are no symptoms until it's too late, until they're already having cognitive impairment in the case of dementia, until they've already had angina or a stent or a heart attack when it comes to atherosclerosis. So early testing, I'll go back to that theme. Early testing is the key to a prevention strategy. Remember that detoxifying homocysteine depends on these 3 B vitamins. And when you find high homocysteine levels, you can prescribe these in specific doses to help detoxify and lower the homocysteine level. Again, early detection and treatment are essential for all of these conditions. Lastly, let's talk about inflammation. And you probably do know that inflammation has now been tied to essentially all of the diseases of aging. And so detecting which of our patients, before they have a disease of aging, let's detect those folks that are headed in that direction so that we can get them off of that inevitable outcome, at least inevitable in their minds, and start on a prevention strategy. Remember that inflammation is actually the first step towards healing. I tell my patients that all the time. Inflammation is not good or bad. It can be both. But initially, it's designed to repair the damage and injury. But if the root cause of damage is not halted, the inflammation itself becomes chronic, and then that inflammation accelerates the damage and the cycle is perpetuated. Everything we've talked about today initiates damage at the cellular level and at the arterial level. And so there's going to be an inflammatory response. Well, let's detect that. Let's find it and do something about it. Highly sensitive C-reactive protein is a nonspecific result to a whole variety of insults and injuries and conditions. So acute infections, viral infections, UTIs, sprained ankles, bad bruises, and a whole host of other chronic conditions can raise the highly sensitive C-reactive protein. If none of those are the case, then the main cause is from visceral fat. The excessive fat that's stored in and around our patients' organs is inflammatory. And in fact, pre-diabetics and diabetics are storing most of their fat there. You can tell these patients when you walk in the exam room, they have the big waistline and it's full of fat that's around their organs. And guess what? That fat produces interleukin-6, which tells the liver to make C-reactive protein. That hsCRP is what we're detecting. And so if it's elevated, their IL-6 level is high. If their IL-6 level is high, it's because they have visceral fat. Again, we can start to engage our patients in understanding that insulin resistance, for example, is a fat fertilizer. And until we address that cause, they're going to have inflammation that's triggering even more damage throughout their body. To use the hsCRP level, optimal is below 1. Again, this is the highly sensitive C-reactive protein, not the regular CRP that the rheumatologists, for example, monitor for rheumatoid arthritis and giant cell arteritis. This is the highly sensitive variety. If it's above 10, they probably have something more serious going on, especially autoimmune diseases like lupus and rheumatoid arthritis, or even metastatic cancer. So really high hsCRP levels need a close look as to where that's coming from. If it's between 3 and 10, that's usually some acute problem like infection or injury and other conditions. But if it's between 1 and 3, these are the folks that it's probably this chronic inflammation, typically from visceral fat, as I mentioned, and these are the folks that are at risk for arterial disease. You might remember that in 2015, the Jupiter trial proved that if a patient has coronary disease and a highly sensitive C-reactive protein of 2 or higher, and you use rosuvastatin in that group, there are significantly fewer heart attacks and strokes. Well, it ties into the fact that rosuvastatin, while it does lower cholesterol, yes, its main benefit is really as an anti-inflammatory. And so that's one of the many trials that's proven the link between inflammation and these chronic diseases. So hopefully you've seen some different ways to use biomarkers, that some of which you're probably already using, but some of which you probably aren't already using. And again, when it comes to preventing these chronic diseases, we want to have early detection so that you can have early intervention.
Dr. David, that was fantastic. I mean, a fascinating way of reviewing those markers, and I think certainly opening all our eyes to, heavenly HDL, certainly packages of cholesterol, suitcases, and all those terms, which I think will be really enlightening for our patient populations that I know our providers are dealing with. So again, what we love about the CIT test is, again, Dr. Wright very kindly kind of articulated the value of all the markers that we've included, but it's also a dry blood spot. So again, that'll make it very convenient in terms of you guys using it in your clinics. Again, it's been validated against serum to 93% plus agreement. It's stable for 14 days. So again, like a number of the other tests that we come out, the food inflammation test, which gives you a great way of working out on an individualized basis what might be going on from a food sensitivity standpoint. With now adding the cardiovascular, that gives you a great way of looking at what might be going on from a cardiovascular health, and some of those great numbers and takeaways that Dr. David was talking about there. That alongside the kind of gut barrier panel and the immune health, I think it's a really great panel of 3 tests that now gives you a great way of trying to really get as Dr. Dave was talking about, the root cause of some of these issues from a cardiovascular perspective, immune perspective, and more importantly, inflammation from a cardiovascular as well as the food sensitivity. So thank you all for your time listening, and stay tuned. We'll make sure Dr. Wright has other kind of clinical pearls that will be coming out with in the coming weeks and months. But again, thank you very much, and excited to hear your success stories as you start using the new KBMO cardiovascular inflammation test. And thank you again, Dr. Wright, for all those great insights into those markers that we've chosen.